The topic is basic ECG. Looking into an ECG in a systematic fashion would involve looking at the rate, the rhythm, the axis, the intervals, and the waveforms, and trying to put everything together, this information, to come to a conclusion, along with the clinical picture, to formulate a diagnosis and how the treatment should go forward. The rate can be measured by dividing 300 by the number of boxes in the RR interval. So if, for example, there are 4 large boxes in the RR interval, the heart rate would be 75 beats per minute. Given that the heart rhythm is regular, this method can be utilized in calculating the heart rate. Looking into the rhythm, it's essential to ask few questions to ascertain what we are looking at. For example, are we dealing with a fast or a slow rhythm, or are we dealing with a situation which is like a regular versus irregular? Do we really see any P waves in there? And if there are P waves, are all the P waves similar, or are we looking at P waves uh, which are very different in morphology? And what's the location of the P wave? Is it really lying in front of each QRS wave? And how's the PR interval like? Is it constant? And are the P waves and QRS complexes associated with each other? How are the QRS complexes? Are they narrow or are they wide? And do we see any grouping of QRS complexes? Are there any drop beats? I'm trying to answer simple questions like whether the rhythm is ventricular or supraventricular. Talking about the P waves with normal deflection and configuration, the origin is SA node. In situations where this is peaked, notched, or enlarged, um, one can think about atrial hypertrophy enlargements. And in case they are inverted, it would be in situations where there is a retrograde or reverse conduction from AV junction towards the atria, and with differing morphologies of P waves, one could think of origin from different sites within the atria, and in certain situations the P waves can be absent. In certain situations, the P wave doesn't precede the QRS complex. In high degree AV blocks, many P waves are not conducted, as many P waves are blocked. In situations where the P wave is notched and is 0.12 seconds wide, um, the left atrium is considered enlarged, and in a situation like P mitrale, um, this happens, and there is a large left atrium due to mitral disease. Looking into the leads 2 and 3, P mitrale can be observed. And looking into the leads 2, 3, and AVF, if there is presence of peaked and 3 mm tall P waves, then the right atrium is enlarged, and the situation is seen in P pulmonale. And what's happening here is there is pulmonary hypertension due to severe lung disease. In a multifocal atrial tachycardia, one would see a pattern where there would be at least 3 distinct P wave morphologies, and visualized best in the leads 2, 3, and V1. In a ectopic atrial tachycardia, one would see the atrial activation, which is pretty regular, but a P wave morphology originates outside the sinus node complex. In a typical AVN RT, which is the AV nodal reentrant tachycardia, one can notice P waves are hidden in the QRS complexes, and they are often buried at the end of the QRS complexes, creating a pseudo small letter case R wave in lead V1 and pseudo small letter S wave, mostly observed in lead 2. In an atypical AVN RT, the retrograde P wave is pretty much well after the QRS complex in the second half of the RR interval. In a AVRT orthodromic type, that is the O AVRT, there is a retrograde P wave, which is frequently seen after the QRS complex, and one can distinguish the QRS from the retrograde P wave. In a junctional tachycardia, the retrograde P waves are frequently buried in the QRS complex. PR interval is the interval that basically, when the atrial impulse travels from the atrium through the AV node, and the interval basically starts with the start of the P wave and extends all the way up to the start of the QRS complex, and the duration is 0.12 to 0.20 seconds, and the duration can vary in certain situations. In junctional arrhythmias or pre-excitation syndromes, the duration of the interval can be less than 0.12 seconds, and in situations of conduction delay through the atria or AV junction, the PR interval can be greater than 0.20 seconds. In digitalis effect, one would notice that the PR interval would be around 0.22 to 0.24 seconds. An interesting sign called as the spodich sign in acute pericarditis, where there would be a downward displacement, which is basically a downslope as the segment is approaching the QRS, and this is called as a spodich sign. Talking a little bit about the Q waves, the Q waves can be physiological, which are also called as the septal, or pathological, which are the necrotic. What's happening is that with the passage of the impulse from the atrium to the ventricle, the left side of the septum is slightly activated before the right, and there's a force generated, which is small, and that force is from left to the right, and that will be recorded as a initial negative deflection. The thing about the Septal Q wave is that these are basically the narrow Q waves, and what's really crucial in distinguishing between a physiological or septal versus a pathological or necrotic Q wave is the width. That's the crucial element. Now, as the cells of the tissue undergo ischemia, there are certain changes brought about in the cells, and that would lead to the dispersion and and slowing down of the conduction of the impulse, and this would kind of distort the depolarizing impulse and bring about changes in the QRS, and basically the initial negative deflection or the Q wave and the so-called pathological Q wave results. And the thing about this wave is that this is wider than the septal Q wave. The normal Q wave is 0.02 seconds wide, and a pathological Q wave is the one that is 0.04 seconds wide. And and there are some Q waves, those are 0.03 seconds wide and are termed borderline, and they are possibly pathologic in nature.